let's turn to the case of a patient who is diagnosed with metastatic lung cancer, has a good performance status, not a lot of other medical problems, has an ALK rearrangement, and has a brain MRI done in their routine staging that shows 4 small and asymptomatic brain metastases. And this is not that rare. We find that patients with EGFR mutations, and especially those with ALK rearrangements, will have a pretty common scenario of brain involvement, and at some point, whether it's initial or over the course of their illness. How inclined are you to favor having them start on the alectinib or some other ALK inhibitor rather than go to the radiation oncologist to get focal radiation to treat those small lesions? Are you comfortable with that, or do you feel that the historical standard of starting with radiation should be the way to start and then proceed with whole body therapy after that's completed? Jonathan?
I'm completely comfortable in patients with ALK metastatic lung cancer with small asymptomatic brain metastases to start off with alectinib, Alecensa. I think, the trials, like the ALEX trial, allowed patients who had asymptomatic brain metastases. And I think that the intracranial, the concentration that gets in the blood with these drugs is basically comparable to the concentration that gets in the brain. It's got great activity in the brain. That's one of the major reasons that patients derive this progression-free survival benefit, is its brain activity. So my practice in those patients is to start out with Alecensa and not do brain radiation. I often have them go see the radiation oncologist to kind of get established, get their input, kind of getting to know you. But I really disfavor brain radiation in that situation, and in particularly whole brain radiation therapy. They can get long-term neurocognitive side effects with whole brain radiation therapy. Now that patients, particularly with these oncogene-driven cancers like ALK, live years and years and years, you want to do it all possible to delay, especially whole brain radiation, to try to really avoid those neurocognitive side effects.
Suki, do you have that same level of comfort?
Yeah, I think if there are 4 very small brain metastases without any symptoms, absolutely. I, like Dr. Riess, also like to involve my radiation oncologist early, at least for a meet and greet, even if there's going to be no treatment offered at that time from a radiation standpoint. At least my patient has met with the radiation oncologist, knows who they are, knows kind of what they do. So if we ever need to use that in the future, that at least is not a total unknown. Sometimes for patients where it's not so straightforward, where the brain metastases are a little bit larger, maybe,
or you have symptoms,
or symptoms like 1.5 centimeters, or if they're in a location where if they grow, it's going to be a really big problem, then sometimes we can even work with our radiation oncologist to treat the most higher risk brain metastases and kind of let Alecensa do the rest in terms of taking care of what may remain.
So I think that that's been a real change, that we have way more confidence in the ability of some of these newer targeted therapies, many of them directed against ALK, some for EGFR inhibitors, especially the newer ones like Tagrisso, osimertinib, for those with EGFR mutations, to expect that they're going to do a good job to treat the disease we see and also suppress the potential for future progression in the brain. And
absolutely. I think the reason why we feel so confident is because it's a nice, at least, from the most basic chemical structure of the drug, that they're looking to see that hopefully this particular drug is going to cross into the brain.
Mm-hmm.
And it's also great to see, clinical trials that are allowing eligible patients to come on with untreated brain metastases. So we do feel confident when a drug like this gets approved in terms of how we
And I
manage
think
our
it's
patients.
instructive now that we have tools that can treat brain metastases.
Yeah.
We're studying that much more. Jonathan, you raised the point that the issue of brain radiation, particularly whole brain radiation, but even piecemeal spot welding radiation with stereotactic radiosurgery, we're much more judicious about this. We didn't used to worry that much about radiation because we didn't have patients living long enough to have this be a complication. And in the patients with driver mutations, we have the good situation of them living for years, now being much more prone to us seeing the sequelae of remote brain radiation, and our concern about over-treating that if we can reserve that option for only the few cases where that's needed.